screen anyway. Okay. So asthma. Okay, so what is asthma? And I could literally talk to you for an hour about nothing else but the immunology of asthma. And I'm only going to put up one slide because otherwise you would get very bored because you really want to know how to treat asthma. So I'm just going to give you one slide. But it is an important slide because what it's saying to you is there are a number of cells, T cells, CD4 cells, T cells, particularly Th2 cells, eosinophils, mast cells and basophils that are key players and that they have direct effect on the epithelial barrier, which is impaired with the environment. They have a direct interaction with triggers like viruses in particular. So 80% of admissions with acute severe asthma, you're going to isolate a virus if you look for it. And they have knock-on effects for airways hyperresponsiveness, this sort of wheezy tendency, which is reactive wheeziness that actually responds to beta agonists, is a direct effect of these inflammatory cells. So it is these inflammatory cells and this inflammatory process that is driving all of the dysfunction in the airway, the smooth muscle, in terms of permeability of the epithelial barrier. That is all being driven by inflammation. And here are the mediators. You know, this is a Th2 process. You're familiar with Th1 and Th2 T helper immunology. So we've got the T helper 2 phenotype, which was originally described as being anti-helminthic, but then it was clearly actually much more to do with atopy, allergy, and various other regulatory processes compared to Th1, which was much more about tumor killing and direct effects in acute infection. Th2 is thought to be more about managing helminth infections and more chronic infection or chronic responses. But it's obviously much more complicated than that now. Okay, here's Shruti. Again, look at all the people in rapt attention. Okay. So the next question is, why do kids get asthma? So the 95% of adults with asthma had, if you go and look at their histories, had their first signs of asthma under the age of 3. So nearly all people with asthma develop asthma or develop signs of asthma under the age of 3. So it's a pediatric problem. What we know is that, however, that the vast majority of people who present with wheeze and asthma-like symptoms in the sort of 1 to 3 year age range, the vast majority of them will not grow up to be adults with asthma. 3 out of 4 of them, their symptoms will appear to resolve, or the disease will appear to ameliorate and resolve by the time they get to adulthood. But in amongst them are a proportion who will continue to have atopy and wheeze right the way into adult life. And there's been huge amounts of research on that. But one set of research that was very interesting is that kids who've been on cardiopulmonary bypass had a far higher chance of having atopy and asthma in older life. Children who've been treated with antibiotics in the first year of life were far more likely to have atopy and asthma in adult life. And the common denominator there appears to be early inflammation. So early inflammatory responses in the first year of life, whether that be the stress of cardiopulmonary bypass or the stress of an acute illness, classically a respiratory viral illness, in particular the commonest one being RSV bronchiolitis, in the first winter season that you're born, the younger you are, the worse, appears to be a powerful predictor of atopy, particularly skin, eczema and atopy. But also of asthma as well. As well as that, there is a strong genetic component. So there are variations that have been described for 20 years on chromosome 17 that are very strong predictors of atopy and asthma. And there are genes that activate various fibrinogenic pathways that are also highly strongly linked to atopy and asthma. However, far more associated are environmental factors, in particular viral infections, air pollution, And previously cigarette smoke, obviously smoking is declining, but in households where there's cigarette smoke is available, rates of asthma are far, far higher. So it's early inflammation. Again, all of these things are early airways inflammation is a key determinant of later asthma. So what happens? Well, this is the bit that we're kind of fairly familiar with from undergraduate days. What we're dealing with in terms of inflammation is its impact on the airway diameter and the thickness of the layers between where the inhaled air is and your pulmonary vasculature, where you move the oxygen out to the rest of your body. So we have obstruction and we have problems with VQ matching related to swelling, mucus plugging, edema, plasma extravasation, and a lot of that, well, all of that is related to the influx of inflammatory cells in disproportionate numbers responding to a non-existent environmental or minimally existent environmental threat. So we've got lymphocytes, macrophages, mast cells coming into the interstitium around the airway and releasing cytokines and causing inflammation, causing swelling, and that swelling has an impact on oxygen carriage, but it also has an impact on airflow through those airways. And that turbulent airflow or restricted airflow is what we can hear when we're listening and we hear wheeze. What we're listening to is a variation in flow with air being blown over the top of partially obstructed bronchi, like you're blowing over the top of a milk bottle. And depending on how much milk you've got in the milk bottle, you get a slightly different note, and that's what wheeze essentially is. It's turbulent flow of one airflow over another airway of different diameters in the respiratory tract. Does that make sense?
Yeah.
To conjure an image.
So it's not the flow through the obstructed airway itself, it's the flow by
the sense of wheeze, the feeling like you can't breathe, is that is the increased respiratory excursions that have to be made to move the air through narrowed airways. But the noise that you hear is air being blown over the top of a partially obstructed bronchi, variable obstruction, which is why you get this kind of polyphonic wheeze. You get these multiple notes of wheeze because you're hearing it all sorts of flow going in different directions with different obstructed airways. Because it's not in a localized position like one mucus plug. It's a global pulmonary pathology. It's across the whole of the lung. All of that airway is inflamed, and all of that airway's got mast cells and T cells in there that are driving this inflammatory process. But we shouldn't forget that it's not only impairing ventilation, it's also impairing VQ matching because of mucus plugging and airway edema and problems with aeration. So it's two processes, and this sort of quite nicely illustrates that thickness related to inflammation of the airway. Okay, so there are reports of what happens in PICU, and there are, over time, there may have been a slight increase over the last 20 years in terms of the number of admissions with acute severe asthma into PICU, but it's not that striking, and there's some evidence to suggest that over the last 5 years there may actually have been a plateau and things have not got any worse. One would imagine that there will be an impact of the COVID pandemic because of the number of children that we saw admitted to hospital with acute severe respiratory illness was profoundly lower. So your anticipation would be there's going to be 2 or 3 years of children who did not get acute severe inflammation due to viruses in their first couple of years. And you'd predict that that would have a knock-on effect on the number of children with asthma in society from that cohort. So I'm sure that's going to be an interesting thing to look at. The other thing that's striking is, in terms of admissions in pediatric intensive care, is the proportions. So like most illnesses in children, males tend to be disproportionately represented compared to females. But also you can see it is weighted towards the younger age range in terms of the proportions admitted to PICU in each of these year groups. Nearly half are admitted under the age of 4, which is kind of consistent with the observation that if you're going to have asthma, you're going to have symptoms associated with asthma before the age of 3, if you look for it.
And you still call that asthma, you don't call it preschool wheeze or virus wheeze.
Well, people are quite sort of cagey about diagnosing asthma because of the fact that most children who come in with one episode of acute severe wheeze will not go on to have long-term asthma treatment. If you say to parents your child's got asthma on the basis of that one admission, you're probably going to be wrong 3 times as many times as you are right. And of course, it comes with a lot of loading. So asthma in parents' minds means here's my child's going to be on inhalers for the rest of their life, and they might die of acute severe asthma, and that's really scary. So pediatricians are a little bit cautious in labeling things early as asthma, even if they're presenting with acute severe wheeze. And the other problem is, of course, that in routine management, inhaled steroid and other modalities that we use routinely in other children's ages don't work well on the under 2s. They tend to be less effective on the under 2s. So again, I think most pediatricians wait, if they can, to see what's going to develop before they label somebody as having asthma. But this group is acute severe asthma. We're talking about on the PICU. So it's also strikingly an illness associated with deprivation, which many illnesses in PICU are. But if we look at the least deprived to most deprived, the most deprived proportion are significantly overrepresented in terms of admissions and need for ventilatory support. So not only are there more of them from deprived areas, they also have worse illness. So deprivation, you could argue, is that to do with housing, diet? Is it to do with cigarette smoking? What is the nature of this? Possibly a combination of all of those things, but definitely deprivation, as with many things in PICU, is significantly associated with admission and death and severity of asthma in PICU. What about deaths overall? Thankfully, so the UK has got one of the worst records in Western Europe in terms of the outcomes for children with asthma. Thankfully, this is not particularly related to deaths. So the overall mortality of deaths in PICU from asthma-related illnesses are about the same as they are in the Netherlands and Australia. So we are relatively representative in terms of deaths. But we have a higher proportion of children who are admitted to hospital with asthma and a higher proportion of children being treated for asthma. And there are concerns about asthma care in the UK that was raised in an article in The Lancet about 5 years ago. But if we look at the deaths of children who are admitted with acute severe asthma to PICU, there are about, in this study in 2022, which is from this data, looking over 2006, 7 and 12, 13, there are about 15 deaths in children admitted to PICU. The vast majority were in the 10 to 14-year-old age group. So what we're talking about is a disproportionate number of children who were admitted were actually in the younger age group, but your peak risk of death is in the 10 to 14-year age group. And we might want to wonder, why would that be? And there are lots of theories about whether this is sort of the development of autonomy, the imposition of treatments by parents. It's much harder to tell a young teenager to use their inhalers or to get a young teenager to communicate with you about how they're feeling or how wheezy they are than it is with a 3-year-old. So the 3-year-old under constant supervision, very easy. Not when I say it's very easy, not very easy, but it's relatively easy to hold them still while you apply the inhalers to them. And they don't have a lot of self-determination. By the time they get to 10 or 11, they're putting themselves to bed. They're brushing their own teeth. They're not necessarily sharing with you how they feel. So they're a particular risk group for death. And this is an age where compliance or adherence to treatment and inhalers probably is going to be very difficult to achieve. But there's an interesting phenomenon, which is as you hit your growth spurt and puberty, and you start to take off, and your endogenous steroid rises, there's often a window where asthma is relatively straightforward to manage, or even disappears, often around the age of about 14 or 15, and then it reappears in people's 20s. So thankfully, at the most difficult part of adherence to therapy, which is sort of middle teen years, there's a biological reduction in the number of children who actually have active asthma symptoms. So that's why this group is a particularly interesting group, because they haven't hit that endogenous steroid peak, and they are still very difficult to get good adherence from at home. And the parents are less involved in supervising them than they were when they were 3. So this is the group that we should watch out for in particular. And referrals from ED of a 10-year-old, I take much more seriously that they could be about to die than I would of a 4-year-old. Usually got much more space with a 4-year-old. Nearly all of the children who died received invasive ventilation. The only one who died in this group who didn't receive invasive ventilation actually died within an hour of arriving, essentially just obstructed and died before they could intubate them. Right. How do we assess moderate, acute, severe, and catastrophic asthma? You're well aware of these. I probably don't need to tell you too much about it, but you know the stuff about being able to talk in sentences, what your oxygen saturation is. Remember, this is also an illness of ventilation perfusion matching, not just the thing that kills them is actually the ventilation perfusion matching, usually not the obstruction per se. It's hypoxia that kills them. People sort of have this idea that it's simply an obstructive disease, but it's 2 things. It's not just one thing. A peak expiratory flow rates, tachycardia, respiratory rate. This is from the most recent SIGN guidance, which was updated in 2019. So I'm going to refer over the next few slides to this national guidance, which is from BTS.
Sorry, could you explain that bit again about there's the 2 things that cause the death?
Yeah, so there's 2 parts to this illness, and the bit that people overlook is ventilation perfusion matching. So we've got this obstructive, people imagine because of the wheeze and the sense of not being able to breathe, and that is very important, that you know moving gas in and out through to the respiratory epithelium is the problem. But as you'll know, if you ventilate somebody with asthma, you can turn the pressures up and turn the pressures up and turn the pressures up. The thing that you can't have the same control over is ventilation perfusion matching. So you know that, okay, let's do a bit of physiology. You know that water holds oxygen very poorly. And so, roughly in terms of carbon dioxide dissolves pretty well in water, 5 times as well as oxygen does. And so getting rid of carbon dioxide from the tissues is relatively straightforward. If you can ventilate somebody, turn the pressures up, then carbon dioxide will leave the body down its concentration gradient and ventilate out relatively straightforwardly. Getting the oxygen down its concentration gradient into the body is more complex because it doesn't dissolve well in the water. So what we have is hemoglobin within red cells that alters that balance. So the hemoglobin avidly takes up and binds to oxygen within the red cell, leaving more space in the plasma for oxygen to dissolve into, which is then taken up by more hemoglobin. So what we have to do is we have to put the hemoglobin very close to the oxygen in the alveoli, and we have to have as minimum barrier to diffusion as possible, using Fick principles. We have to have the minimum distance and the maximum surface area so that oxygen can dissolve into that plasma and be taken up by the hemoglobin. So matching where the hemoglobin goes to where the aeration occurs is the key part of oxygenation. It's ventilation perfusion matching. If you've got an illness where you've got plugging off of airways, impairing ventilation perfusion matching, plus edema and plasma extravasation, alteration in Starling forces related to that inflammation, that's making the diffusion of oxygen less advantageous. You might even have time diffusion limitation if you've got enough of a thickness of your alveolar wall. You know, this idea that the oxygen in you and I, so it takes about a second for the blood to leave the pulmonary artery to reach the pulmonary vein, just under a second, about 3/4 of a second. The process of diffusion and absorption into red cells is complete within 1/4 of a second. So, you know, in a fraction of that period of time, you've maximally oxygenated all the hemoglobin you possibly can. If, however, your alveoli are thickened with inflammatory cells, and it's now going to take a lot longer for your oxygen to diffuse from the alveolus into the plasma and then be taken up by the hemoglobin, you might actually find that it takes more than 1/4 second or more than half a second. And you can actually find in certain situations it's more than a second. So the hemoglobin has gone through from one side of the pulmonary circulation to the other without picking up oxygen because of time diffusion limitation. And that is something that can occur in many inflammatory conditions, but certainly in acute severe asthma. So you've got diffusion limitation, ventilation perfusion matching that can make you hypoxic.
And plugging, right, as well. So you're just not
Plugging,
ventilating.
you're not ventilating. Yeah, so you've got mucus in there.
Yeah.
Oxygenation is going to be impaired by mucus, stopping oxygen reaching anywhere near where it can diffuse into the plasma.
This might be
That makes sense?
Yeah, thank you.
This might be a question for another time, but in my mind, then we use nitric when we're kind of running out of options.
Yes.
And my understanding is that nitric just causes a global pulmonary vasodilation. So you're maximizing your perfusion of areas, but then wouldn't that cause other areas that are not well ventilated to also be well perfused? So that just makes things worse.
No, it does. So it theoretically works because, as you know, nitric oxide is EGRF, isn't it? It's endothelial-derived relaxant factor. So it's made in response to nitric oxide synthase, which is in the endothelium in your pulmonary circulation anyway. And usually there's no autonomic innervation of your pulmonary vasculature. So instead of like your arterioles in your periphery that are being moderated by alpha-1 sympathetic nervous system so that you can move blood around, in the pulmonary circulation, there's no significant autonomic innervation. It's being auto-regulated by pressure, by airway distension, by surfactant reducing alveolar surface tension, but in particular, it's being moderated by hypoxia. So the blood tends to go where there is oxygenation, and that is being driven by relaxation of those pulmonary capillaries by nitric oxide being produced endogenously in the wall in response to oxygenation. So if you've got hypoxia, you get vasoconstriction, and the idea of that pulmonary vasoconstriction is to deviate to more preferably oxygenated areas in the lung. But if your system is overwhelmed, you can improve ventilation perfusion matching by simply opening up everything and getting as much oxygen in as you possibly can from the outside, swamping the whole system by vasodilating everything. It works particularly well if you can improve the perfusion pressure. So if you can push the mean arterial blood pressure up, you also get stretch-related opening of those pulmonary capillaries as well. So the two things together are supposed to be able to improve the entry of oxygen into the circulation.
And the nitric will only get to the bits that are ventilated anyway, right? So it's not like you're going to get. So you'll get selective areas being.
Yeah, you'll get a certain amount of swamping of everything.
Yeah.
Because you're putting in enormous quantities, which is why it can be so difficult to turn on the endogenous nitric oxide afterwards. Because as you turn it down, it's like all been switched off everywhere else because you're absolutely swamped with nitric. So it can be very difficult to wean it off. So that's the theory behind nitric is that you're just opening up as much vasodilation as possible within the pulmonary capillaries. Right, so obviously we're going to get sicker here. So we're going to go from it being able to talk in sentences, not being able to complete sentences in one breath, from essentially normal saturations to VQ mismatch with low saturations, to tachycardia related to that hypoxia and stress, to tachypnea related to switching on of that respiratory drive through chemoreceptors. And then we're into death, aren't we? So at this point, you know what they look like. They look exhausted. They look tired. Their saturations are low, despite oxygen. They may be hypotensive as well. They may have, degree of vasodilation related to carbon dioxide, but they may actually be hypotensive. They may look blue, but that is really difficult to identify. So, kids come in with saturations in the 70s and they don't look cyanotic to us often. So to really look blue, you're about to die. So if you can see cyanosis, they are about to die in the context of an acute severe change. You and I won't notice hypoxia generally until we hit saturations in the middle 80s. So we won't even really notice that we're hypoxic. Our hypoxic drive kicks in at around 60 millimeters of mercury when, we've got a continuous CO2 drive that's being measured centrally, and that's generally driving our tidal volumes and our respiratory rates. But hypoxic drive doesn't kick in till we're around 60 millimeters of mercury of oxygen. So we're quite hypoxic by that stage, but we won't even notice it. We won't really notice it. And our sats will still be in the 80s. Once we get down to the low 80s, we'll feel breathless. Once we're blue, we'll feel really breathless, really, really breathless, because our saturations are probably going to be in the 60s or 70s. But you as a doctor won't even see that they're cyanos. They might look a bit pale. They may not look blue, but you'll know they're ill. When you listen, a silent chest is bad, as you can imagine, as we've all been told. But actually, it's remarkable how many times somebody says to you, on the phone, you ring up and ask, how are they doing? You've given them a salbutamol nebulizer. Oh, they seem much quieter now. And when I listened, I couldn't hear the wheeze. You can interpret both those in two ways. One is they're now exhausted and about to keel over, and the absence of wheeze could be a silent chest. So it's not always what you want to hear down the phone. Does that make sense when you're ringing the ED? Confusion is obviously of great concern. Right, therapies.
My little chicken that's coming back tube, do you really want her infusions?
Okay, so we're back to the sign guidance again. Asthma therapies. So one of the standard therapies is obviously salbutamol, in particular terbutaline in other countries, but salbutamol in the UK, as an inhaled beta-2 agonist. So what we're talking about is adrenaline-like synthetic agent that preferentially binds beta-2 receptors over beta-1 receptors slightly. It still has cross-reactivity with beta-1 receptors. So whereas beta-1 receptors are predominantly cardiac receptors that make you tachycardic and all that kind of stuff, beta-2 agonists in this context, as well as being in some other places like skeletal muscle and in the kidney and coronary arteries, but also it is a smooth muscle relaxant for bronchial smooth wall. So what we're smooth muscle, what we're asking it to do is to reduce bronchospasm. Remember that bronchospasm is being driven by the inflammation, by cytokines, by mast cells, by T cells. So that causes the smooth muscle in the airway wall to become hyperreactive, to tend to constrict more readily. And so by giving Ventolin, salbutamol, what we're doing is we're directly adding an agent to make that smooth muscle relax. The issues that we might want to consider are that generally beta-2 agonists are short acting. So you don't buy much time. Inhalers buy you, or even IV, once you turn it off, buys you probably 35, 40 minutes, and then it's gone from the system. And the other problem is that beta-2 receptors, over a period of time, if they're continuously exposed to high concentrations of an agonist like salbutamol, they slowly downregulate a process called tachyphylaxis. So oftentimes in acute severe asthma, the parents have already started giving regular salbutamol at home. They've probably given it for a couple of weeks, might even been told, oh, yeah, it's okay to give 10 puffs, if it's not working. We've seen cases where children have come in having had 2 weeks of the parents trying to keep them at home, giving them lots and lots of inhaled beta-2 salbutamol, and it's not effective anymore because they've downregulated all their cellular receptors for salbutamol.
Even IV.
Even IV.
Yeah.
So you might find that some of these children who've been treated for a prolonged period of time with sort of this, severe wheeze that's been going on for a while, with inhaled salbutamol, have little or no response to treatment, which can be quite daunting. So if you give them an inhaler and absolutely nothing happens, then probably one of two things is going on. One, their tidal volume is just not allowing it to get to where it's supposed to be, which is common. Or two, they're not going to respond particularly well to inhaled salbutamol. And those are both warning signs that you can't walk away from this kid. We need to think of another approach because this kid's going to be in trouble. So if you get a kid and you give them some salbutamol and they react nicely and you get improved, that's a really nice feeling. It's a positive feeling. It means I've got a little bit of time and space here where I can manage this child. This should work for 35 to 40 minutes and I can repeat it if I have to. And they're probably going to respond again to beta agonist. If they don't respond to that first inhaler, that's a big red flag. We should be concerned. Don't walk away and come back an hour later, would be my advice. And you can then give, instead of just 10 puffs of a MDI and spacer, you can then put them on continuous nebulizer, what you have to do. But you should already be thinking, I need to get some IV access into this kid. I need to think about how I'm going to deliver these steroids, and I need to give them very, very early to this kid. And I'm not going to take my eyes off them because they will just not improve. So there it's on the slide, gives oral steroids early in the treatment of acute asthma episodes. So there's nothing to be lost in giving them an early dose of steroid. Lots of children will not absorb. If they're that sick that they're not responding to their beta agonist, they will also have a degree of gastric stasis, and they will not absorb their steroids if you give them orally. And the other thing you don't want them to do is to vomit back up, which they do if they're coughing, and they're very, very sick, and you give them the oral steroids, they'll cough, and vomit it back up, or it'll just sit in their stomachs and not be absorbed with a shed load of mucus. So again, oral steroids early, but that doesn't mean you're not going to move on to intravenous steroids at an early opportunity if you get vascular access, because the only thing that's driving this is inflammation, and the only thing that's going to reverse that is the apoptosis of those mast cells and those lymphocytes that are driving that inflammation. And that's the only thing that's going to reverse this process. So you're buying time with the beta agonist, and it's working on one very discrete part of the anatomy, which is the smooth muscle. That's all it's working on. It's not managing anything to do with the inflammation. And the underlying process is this inflammation, and the treatment is steroids. It's basically the apoptosis of those cells. Right. Not recommended therapies that you will see being given all over the place. Magnesium sulfate nebulizers are actively discouraged in adult practice. For some reason, they are still being used a lot in pediatrics. There is no evidence to support the use of inhaled magnesium sulfate. It's still in the algorithm that you can consider it, but there is no real... Oh, great. Okay. Zoom recording. See? Recorded. Okay. So other stuff, additional therapies. once you've got vascular access, IV salbutamol, if the inhaled salbutamol is just not going in because there's no tidal volume being generated, plan B, and definitely on a ventilator, it's an easy way to deliver it, is to deliver intravenous salbutamol. And you can give that as a bolus to start off with. It'll buy you 35 minutes to 40 minutes, just like that. And then infusions as required. Magnesium sulfate IV is a sensible adjunct if people respond poorly to inhaled salbutamol. Early magnesium sulfate can be, a major game changer. That does cause hypotension, so it needs caution. For some children, you need to give fluids with it, and they certainly need monitoring. You can't give it and walk away. Aminophylline, although it's not recommended in children with mild to moderate acute asthma, if you're in a life-threatening situation and you've already given salbutamol and maximal bronchodilators, it can have an additional effect. So it is a sensible drug. The problems with aminophylline for us practically are it needs ECG monitoring. So we're slightly reluctant to have people put on aminophylline in ED as a kind of knee jerk, because it means they all have to come into HDU for additional monitoring because there's no cardiac monitoring on the wards. So that's not to say that I don't recommend you use it. It's a good drug to use, but the context is everything. And it shouldn't be just used willy-nilly because it does have impact on where patients can be nursed. Right, ketamine. So I know we use a lot of ketamine for induction, and it's widely used for induction of anesthesia in sepsis and shock, and it's being used in trauma, and it's a good drug. It's very frequently used in acute severe asthma, and it doesn't do any harm. However, there is no evidence of the use of ketamine in terms of bronchodilation or improved outcomes using ketamine compared to with any other agent. Having said that, you'll very frequently see kids being intubated with ketamine in ED. Sevoflurane, there just isn't enough evidence or data about the use of sevoflurane in asthma. It's not an entirely benign anesthesia agent, and it is technically complex. We don't use inhalational anesthesia on the unit here. Part of that is because largely we're not staffed with people who are anaesthetists, who have access or the competencies to manage an anesthesia machine, which is how it would have to be delivered. But the data on the use of sevoflurane is very limited, so I don't think we're missing out in particular. But you'll hear it raised often. Right, and here's the complex stuff. And there aren't answers to it. There is no data on any of this stuff in children. So we can simply talk about how we might approach some of these children. So ventilatory modes, we are commonly using PRVC, volume control ventilation, which offers advantages and disadvantages. The advantages that it offers us is that the machine will alter the pressure according to the volumes that we set, and therefore the need to manipulate the settings on the machine are very reduced. So we used to use BiPAP here 15 years ago, and the problems were with teams on overnight. You'd come back in the morning and there'd be a massive variation in how often you had to do blood gases and how the machines were being managed by the nursing team or the junior doctor team that was on. And starting PRVC essentially removed the need for registrars to go every 4 hours and twiddle with the pressure control on the machine in response to a gas or an end-tidal CO2. Volume control modes are favored in asthma, in acute severe asthma, generally in the adult cohort. The disadvantages, of course, are that you can generate a lot of barotrauma with high pressure ventilation if very quickly things change, particularly with mucus plugging or changes in position. So it's not without a downside. But I think on balance is preferred for most kids with acute severe asthma. Using the waveforms, you've seen the flow volume loops on the servo eye. The optimal inspiratory flow waveform is hotly debated. I think the problems with the waveforms is that you can see quite a lot of variation breath to breath, and with repositioning that can make interpreting the inspiratory flow waveform very difficult on the servo eye. But it is, with experience, it's certainly something that we use. What we want to do is not to over distend, so we want to manage hyperinflation by monitoring the inspiratory portion of the waveform and balancing it against PEEP, and preventing hyperinflation as best we can. So it's keeping that hysteresis curve in the maximum slope so that small changes in pressure generate the maximum volume change and not over distending or under distending so as to cause volutrauma or barotrauma.
It's not the expiratory flow waveform at all.
And the expiratory flow waveform is also important, because what we don't want to do is to cause dynamic recruitment of FRC. So if we don't allow for sufficient expiratory expiration, we're going to get breath stacking with hyperinflation related to that. So yeah, the inspiratory flow waveform is important, but the expiratory flow waveform, and certainly the termination of expiration, is very important. So both can be used to inform how we ventilate patients, what our inspiratory time is, what our expiratory portion is, what the I to E ratio is, what the overall rate is, can be influenced by both those waveforms.
Do you want a very quick inspiratory time so you can probably, I guess it depends, doesn't it, on what's going on for
it's a guide, but it's a context thing. So it's not as straightforward as a switch, it's not a binary process. So what we want to do is we want to see the inspiratory flow waveform with a rising volume during the whole of inspiration, but not reaching maximum inspiration and therefore getting a spike of a plateau spike of which will be associated with a pressure spike if we try and increase more volume. At the same time, with expiration, we want to make sure expiration is completed, if at all possible, before we initiate the next breath, or we're going to get, a dynamic recruitment of FRC and hyperinflation. And monitoring of hyperinflation, how we monitor that is tricky. So a lot of people will ask for a chest X-ray after a period of time on ventilation to monitor the hyperinflation. The question of how often you do that is very complex. And another way, of course, to do that is visually, to go to the bedside, look at the inspiratory flow waveform, look at the expiratory flow waveform, and look at the chest rising and falling. And if you're looking at the chest reaching maximum expansion, you probably want to alter the point on the hysteresis curve that you're on. Some people use wheeze as a guide. So if you give any extrinsic PEEP, you will distend those partially obstructed airways that we're talking about, where the wheeze comes from. And you may actually abolish wheeze completely if you turn the PEEP up. In fact, you will. I can guarantee you will. What most people would do is say that that's gone too far. You've used too much expansion if you've abolished all wheeze. And what we'll often do is turn the PEEP right down, have a listen, and then gradually escalate the PEEP until we start to see an amelioration of the wheeze. But we won't go up to the point where all the wheeze is removed, because that would imply overextension. And when you go to examine a patient on a ventilator who's got acute severe asthma, the PEEP can get in the way, and you sometimes, for that examination, removing the PEEP so you can actually assess the wheeze more fully is necessary at the bedside.
Isn't listening to wheeze kind of less helpful than looking at how they ventilate?
Totally. These are just factors. So, using the waveforms, they take experience. Looking at the patient's chest expansion takes experience. You're looking at the listening to the wheeze is one factor that we factor in. None of these are evidence-based. The PEEP in adults is evidence-based. So the use of extrinsic PEEP is discouraged in adult patients. But children are slightly different in that they can breathe out to the point of reaching closing volume. And we need to factor that in because you'll be removing portions of lung that will be necessary for ventilation perfusion matching if you reach closing volume. The administration of beta-adrenergic agents, also very controversial. So despite compensatory mechanisms within most ventilator systems, there tends to be a loss of recruitment by adding in flow from extrinsic inhaled nebulized beta-adrenergic agents. And they should be used with caution because you can get collapse, relative atelectasis related to the administration of an extrinsic inhaler. And so you should assess what actually the benefit of that inhaler has been each time you do it, and keep your eyes open to the fact that you could be making the situation worse. Another alternative, which is smoother, is to give intravenous salbutamol. The downsides of intravenous salbutamol are that you can get massive tachycardia, that the smaller the children are, the less well they tolerate it, and you can get very frequently, you can get a rising lactic acidosis that can limit your ability to use intravenous Ventolin. So a lot of people will have a top heart rate, which they won't allow to go above. My personal peak is 180. I don't want the heart rate going above 180. So if you're turning the salbutamol up and the heart rate's reaching 200, you've gone too far and you need to back off, would be my advice.
So you're saying that
there's no evidence on any of this stuff, though.
You'd avoid giving entrained nebulized salbutamol in integrated asthma.
You might do. I'd say you have to assess the effect of that inhaled beta adrenergic agent, because you may induce atelectasis by de-recruiting during that procedure. It's very difficult at the flow rates that the machines are generating to keep up with the nebulizer requirements as well, and you often get a de-recruitment associated with it. So I'm not saying don't give it, I'm just saying be aware that there's a potential downside and you have to keep looking for that downside. So if you're giving beta adrenergic agents and you're seeing a progressive worsening of VQ matching, that could be the asthma is getting worse, or it could be that you're de-recruiting them and that it would be smoother with intravenous agents. Alternatively, you could be giving an intravenous agent and they've got a lactic acidosis and a heart rate of 200, they're just not tolerating it, in which case it might be less toxic to be giving it as an inhaled beta adrenergic agent. It's not binary, it's complex. It takes judgment. Humidification, very important. Weaning modes, exquisitely complex, all sorts of proposed algorithms for weaning. There is no solid evidence base. There is no evidence base, although we often do it for proning children with severe VQ mismatch in asthma. Clearly, it's going to alter the flow dynamics of ventilation quite considerably, but we often do it. And then there's this concept of critical illness polyneuropathy, which, or I put myopathy there, that should be polyneuropathy. So very common in respiratory illnesses, particularly associated with steroid administration. And so the asthma group are particularly vulnerable to a critical illness polyneuropathy that has to be looked out for and can impair weaning and extubation of children with severe asthma, that we just have to be alive to it, really. Right, that here endeth the highly controversial area, I'm afraid, of management of acute severe asthma on the PICU. Thankfully, as you can see, only 15 deaths a year. It's relatively rare that we run into trouble. We did run into a child who went down to Great Ormond Street to be close to ECMO about 3 weeks ago with acute severe asthma. But generally, kids with asthma, A, don't end up on PICU, which is great. They get managed in the ED frequently or on the wards, and they don't end up in PICU. And B, if they do end up on PICU, they tend to do quite well overall.